Wonderful. Our next speaker, so we have a little bit of a change in the program. There are two speakers who are not able to make it. So we are making a small change. So our next speaker, again, does not require any introduction. That is Dr. Jorge Kattah. A couple of years ago, the FINO organization meeting in Colombia, Bogota, was in honor of Jorge, as you may all recall. Jorge is the head of neurology at University of Illinois in Peoria, and he is one of the very well-known neurotologists through the world who had done remarkable discoveries and showed us and showed ED physician particularly what is important of hints and how to diagnose the acute vestibular syndrome. Before making any more delay, I want to hand the stage over to Jorge because he's on call, he said, and he probably has to treat some acute vestibular syndrome live. Please go ahead, Jorge.
Thank you. All right, let's see. Okay, where is my... Can you see my screen?
Not yet. You will have to click on the share screen green button in Zoom.
Okay. What happened? Why did I share?
Yeah. Yes, we can see your screen now.
But now I don't see where my presentation is. Huh. It was down here.
You could minimize this. Yes, you could minimize all the windows. And then you will be able to see your presentation.
Where is it?
The bar which is below, can you see the PowerPoint in that?
Is this here?
Yes.
It's opening again. How about now? Can you see it?
No, not yet.
Gee, resume share. Now?
Not yet. You could click on the share button.
I see.
1 minute. Let me do one thing.
I found it here. Let's
yes,
see if that's
yes,
it is there?
Yes.
Perfect. All right. So I first want to thank you very much for the invitation, and I presented some of these recently to maybe some of the same members. We're just going to try to do an update on the status of the hints, and particularly as it applies to the diagnostic of an acute vestibular syndrome. As you know, the acute vestibular syndrome is defined as the sudden onset of acute vertigo, nausea, vomiting, and head motion intolerance associated with nystagmus. The lesion that causes this may originate in the peripheral vestibular structures, which is the most common location, or in central vestibular pathways that include the vestibular fascicle and the vestibular nucleus, or in structures that affect the VOR, that will be in the brainstem and the cerebellum. So the head impulse test, which is the first component of the hints, was first described by Michael Harmaghi and Ian Corjuez in 1988. It tests it consists of a rapid acceleration of head movement in the plane of one of the semicircular canals. Here we'll be focused on the horizontal canal. This triggers an eye movement in the opposite direction in order to maintain fixation. So here it goes. We move the head to the right, the eyes move to the left, and actually, in here we see a normal head impulse test. The eyes move to the head moves to the right, the eyes move to the left. And in here we have an abnormal one. There is a deficiency of the signal from the horizontal canal, and then the patient has to refixate. That contrasts with the normal side. And this is, again, a sign of vestibular paresis, most of the time peripheral in localization. So this is a patient with an acute vestibular neuritis, in whom we're going to see a positive head impulse test. This is day 2 of the vestibular neuritis. She's got a horizontal left pit nystagmus that is not well suppressed with fixation. And then when we do a head impulse test, you see when she moves the head to the right, there is a refixation saccade to the left, because there's a deficiency on the signal from the right vestibular periphery to the ocular motor neurons. So once it's here, a graphic of the reflex, we move the head to the left, and then the left horizontal canal sends the signals to the contralateral sixth nerve nucleus that engages the motor neurons of the lateral rectus, and via the Coumadin MLF engages the medial rectus neurons, and then you have a movement of the eyes to the left. This is a coronal section showing all the 4 vestibular nuclei and the pathways that include the contralateral sixth nerve nucleus, and from the nucleus, the interneurons then cross over and come to the medial rectus neurons. If we look at the vestibular receptors and the brain stem, we see that here is the horizontal semicircular canal. This will be the vestibular nerve and the root entry zone here. And then here we'll have the fascicle that brings the vestibular stimulation to the vestibular nucleus. So in this pathway that includes 2 neurons, any lesion here can potentially affect the vestibulocular reflex and therefore result in a positive head impulse test. Most of the lesions will be, of course, located in this area, but there will be central lesions that will cause a positive head impulse test, albeit uncommon. This is another view of these structures. Here we have the vestibular nucleus. Here we have the root entry zone. And importantly, we have here the vestibular fascicle. The transition of peripheral myelin to central myelin occurs here. But so that indeed this will be a central lesion by classification, but it's part of the afferent arc of the vestibular apparatus. From the vestibular nucleus, then we'll go and engage the 3rd neuron of the vestibular arc, that are the oculomotor neurons, to importantly engage the vestibulocular reflex. Dr. Gold this morning created a nice cartoons illustrating the oculomotor pathways. And what is the main difference here is that the projections from the receptors go right to oculomotor neurons, bypassing the PPRF and the RIMLF that are necessary for the integration of eye movements that are not vestibular in origin. All right, so our first study, we began looking at our patients in the head impulse with head impulse test, probably in 2000, maybe a little bit before. And that was about 11 years after Michael Halmagyi and Ian Korthoff had described the head impulse test. And we utilized it and found that it was quite helpful, but not the answer alone. We concluded in that paper, this is from the paper, a positive horizontal head impulse test may be seen with lesions in the pons and cerebellar strokes. So the sign presence cannot solely be relied upon to identify benign pathology. One has to consider direction of the nystagmus, severity of the truncal instability, and the nature of the hearing loss. In our series, we had 34 patients with a stroke. 31 had a normal head impulse test, but there were 3 patients who had a stroke and had a positive head impulse test. That's from the first paper. One was involving vestibular cerebellar structures, one was a pontocerebellar stroke, and the third one was a pontocerebellar-labyrinthine stroke. All right. So there was need for a solution to this problem because the head impulse test was definitely helpful in localizing lesions responsible for an acute vestibular syndrome, particularly when nystagmus was present. In acute vestibular syndromes, if the horizontal head impulse test is normal, it indicates that the VOR is normal, thus providing unequivocal evidence that the lesion spares the vestibular periphery. Therefore, a normal head impulse test in an AVS suggests a pica vascular territory location. However, some lesions involving the ICA vascular territory may cause a positive horizontal head impulse test. And as I say, there was indeed need for a solution to this eventuality. So this gave origin to hints. And here I'd like to comment on and recognize David Newman Tucker, who was my collaborator throughout all this work. And parenthetically, I can mention that when we wrote the paper, we had entitled it Subtle Eye Science to Differentiate Central versus Peripheral Causes of Stroke. And one of the reviewers, actually Scott Eggers, wrote back saying, consider changing the title because anytime anybody is going to read subtle, they're going to pretty much ignore it. So that night, David slept over this issue, and the next morning he came out with the acronym HINTS, which refers to the head impulse test that we had studied initially in the first paper, but then we added a combination of horizontal nystagmus direction and test of skew, and that led to the acronym HINTS. And then the INFARCT, a mnemonic, suggests that impulse negative, fast phase of alternating nystagmus and refixation movements in the cross-cover test suggests a stroke. And this was the paper. It was actually published in 2009. It's pretty amazing that this is actually almost 11 years since then. The horizontal, the direction of the nystagmus was subject of a review in the New England Journal of Medicine that Dr. Hudson and Dr. Balo had published based on their experience. And of course, if the nystagmus was vertical or purely torsional, the lesion was unequivocally central. The issue was more, a problem was with horizontal nystagmus. So a typical peripheral nystagmus is unidirectional and is very brisk when you remove fixation. Some central nystagmus can also increase with fixation removal, but it's not as pronounced. What was clearly always central was a direction nystagmus that changed with the gaze direction, not like the patients that Dr. Asprella and Dr. Sumamaya were telling us direction change of the nystagmus with head position, but here is with eye position by looking in eccentric gaze. So if you see a central direction change in nystagmus, that will always be central. Unless it's spontaneous, which is what will happen in some patients with Meniere's if you catch them from the onset of the attack to the subsequent phase. And we have to remember that fixation removal can also increase the nystagmus with central lesions. So here we have a patient with a direction changing nystagmus. And we see here that he's got a horizontal right beat nystagmus. As you can see, he's in the ICU with a nasal cannula. He seems pretty comfortable here. The nystagmus increases in right gaze, follows Alexander's law. Thus far, this could also be central, but the key here is that he's got a nasal cannula, so he's not just a common garden variety peripheral case. And here you see how he changes the nystagmus direction with gaze positions. There's a horizontal left beat nystagmus there. Head impulse was normal. And then in addition, when he looks up, here, he's got an upbeat nystagmus. Obviously, that combination is clearly central, and the head impulse test was normal. So this patient was admitted in observation. He had a CT scan initially that showed a cerebral stroke, and these cerebral strokes are like an atomic bomb. They are brewing there for 1 or 2 days. The patient just had vestibular symptoms, nothing else. We're following him up, and then all of a sudden, this stroke grows. It becomes ischemic edema in the posterior fossa. It herniates, and then the patient needs a shunt, EVD, external ventricular drain to deal with the acute herniation. And had we ignored the nystagmus direction changes, he could have been classified potentially as a peripheral lesion, and then would have come in later with signs of herniation. At that point, clearly the lesion was central. So the idea is to catch these cases early on. Some specific points about the nystagmus direction change here. Note that the analysis of the direction change of the nystagmus fast phase refer to the change that occurs with different gaze positions without changing the head position. And the mechanism to develop an acute vestibular syndrome in the stroke of the cerebellum is the sudden loss of GABA, alpha, and beta mediated inhibition of the ipsilateral vestibular nuclei. This results in an asymmetry of the vestibular tone. Here we have the stroke in the cerebellum, and then this will be the mechanism, right? The flocculus primarily inhibits the ipsilateral vestibular nucleus. When you have less GABA here, the resting rate of the vestibular nuclei in the same side of the stroke is increased, and that creates this equilibrium, and then that leads to the acute vestibular syndrome. Note that the nystagmus is ipsilesional. So the patient that I showed you had a right beat nystagmus in primary gaze. The stroke was in the right side as well. Unlike peripheral vestibulopathies, where you have a nystagmus that beats away from the side of the lesion. 2 points to make about spontaneous horizontal nystagmus. Dr. Sprella told us about this morning. If the nystagmus is horizontal, check the head pitch test with the patient seated. If nystagmus changes direction, it will be a pseudo-spontaneous nystagmus related to horizontal canal BPPV. And the same will apply to extending the head. When the acute vestibular patient is sitting up and looking at a straight gaze target, finding vertical or purely torsional nystagmus requires urgent neuroimaging and close patient monitoring. The same will apply to lateral gaze horizontal direction changing nystagmus. Okay, in a cohort of the second paper, we found a straight ahead horizontal unidirectional nystagmus in all the patients with vestibular neuritis, but there were many strokes that had the nystagmus was unidirectional. So here we needed the head impulse test to sort them out. Horizontal gaze direction nystagmus was seen in 20 of the 62 cases. And then we had only 8 patients with horizontal gaze evoked nystagmus only, and 6 patients with vertical torsional nystagmus. So the other component of the trial was the skew deviation, and that was present on a routine cross-cover test as part of the neurologic exam.
In the evening of Sunday morning, Saturday night and Sunday morning, he woke up and had a problem with his balance and went back to sleep. And then when he finally woke up in the morning, he had significant unsteadiness and you were falling to the right. And so he went to the emergency room locally and then was referred here. So we saw him about 2 p.m. yesterday. That is about 10 hours after the onset of the symptoms. Now you see 2, right? one on top of the other. Yep. All right, I'm going to cover your eye and then keep looking. Yep. And one sees a right hypotropia and a left hypertropia. The other point is that his Horner syndrome seems to be more clearly defined.
All right. Bear in mind that those patients were not complaining of diplopia when they first came to see us, because the intensity of the acute vestibular syndrome was such that they probably ignored that complaint. We saw this during the testing. And then as the nystagmus decreased in amplitude and intensity over the following hours, then the patient did describe diplopia. In addition to that, sometimes we saw a head tilt, ocular torsion like we saw here, and then we can actually show how we can measure the skew deviation. Here the eye is occluded, and then when we uncover it, then it comes from down up. So this is a right hypotropia, showing that the lower eye is in the side of the infant of the right medulla. This patient actually had an upbeat nystagmus. Dan talked about this earlier today. All right. So it is known that the sensitivity of MRI in a stroke in the first 24 hours is less than 100%. And in our patients, it was falsely negative initially in 8 cases. On the basis of the clinical findings, we elected to repeat the scan and then confirm the stroke. The first 3 patients actually was very interesting because we were not aware of this, and I had to talk to radiology and convince them to do a limited version on MRI. Subsequently, then we learned that this was a possibility, and we kept ordering the scan in the cases that we thought it was false negative. So in our cohort, in that paper, was 11.4% of the stroke patients had a false negative MRI. And then here we have how the dangerous trial had higher sensitivity, but it was a little less in specificity, as one of the patients with vestibular neuritis had then a 3 prism diopter skew deviation. And this is a summary of the cases. So the positive head impulse test was seen in 25 patients with peripheral lesions and 3 patients with a stroke. And among the pica strokes, 62 of 67 had normal head impulse tests. We could not examine 4 patients due to encephalopathy or ophthalmoplegia. Well, I thought that we were done with false negative MRIs for about 2 years. We had no cases, but this patient had a cerebral stroke, and we instructed her that if this syndrome occurred again, to come as soon as she could. So she did. She presented with acute vertigo about 1.5 years after the stroke, nausea and vomiting, and was here in the magnet at 1.5 hours and had a normal MRI and changed, well, not normal, had the old stroke. And then we repeated the MRI, and the next day, because she had compelling central signs, and then we see here the stroke. And this is not a small lacunar stroke. So this confirms my thought that what is happening is the tissue is ischemic. It's not infarcted yet. It's ischemic to the point that it causes symptoms, but the damage is not complete, and therefore you don't see the diffusion restriction. So it all depends on how early you are looking at the patient. This could have been at some point, perhaps a TIA, if one could predict and actually figure out what to do with the case and give a thrombolytic agent that will work well. So that false negative MRIs are probably due to the fact that the tissue is ischemic, but not infarcted. Now, that needs to be proven, obviously, but this case was amazing because this is a big stroke. This is not a little stroke. All right, so the hints over the last decade has performed well in many series from different places. This is Australia. This is the Korean group, Spain, Kevin Kerber in Michigan, Sergio in Buenos Aires, and from Florence in Italy. And they found the hints to be helpful. Dr. Kerber actually suggested that the ABCD score combined with hints will actually have increased sensitivity. And to be said also, he didn't have, I think had only one false negative MRI. So I guess our biggest problem for a false positive head impulse test is the ICA stroke. And the problem, of course, comes from the fact that the ICA is a branch from the basilar artery, and all circulation of the membranous labyrinth comes from branches from ICA, the internal auditory artery. So that remains a diagnostic challenge. We wrote a paper in response to the ABCD2 score paper, and there we found that hints was had more sensitivity, mostly because we had a number of patients, including the one with the skew deviation, that were young, were much less than 60 years old and so on, and they had a lower ABCD2 score than the older patients. So we found that hints was probably higher sensitivity. In this paper, we also noted that acute hearing loss and acute vestibular syndrome at the same time is very suggestive of a vascular event. Since then, there have been additional findings that perhaps can be added. Head shaking is one, because it can cause a central nystagmus that may be vertical, or which was called perverted, or a nystagmus that beat toward the affected ear with head shaking. And of course, the additional central signs, including the ataxia of the trunk that Sergio will be talking more about when we conclude here. So where are the lesions that can cause potentially abnormalities of the VOR and have a positive head impulse test? They may be located in the pons. We mentioned vestibular root entry, vestibular fascicle, medial vestibular nucleus, or in the medulla, the caudal medial vestibular nucleus, or the nucleus prepositus hypoglossi, which is the velocity storage site. And then, of course, in the cerebellum, lesions in the flocculus can cause abnormalities of high velocity VOR that are usually contralateral to the lesion. So I have here an example from Dr. Kim showing a vestibular nucleus lesion. In these cases, the head impulse test is bilaterally abnormal, more so to the same side, and very likely that those patients are going to have direction change in nystagmus. So you will have all the elements of the exam that are going to help you figure out what the lesion might be, and that is not just a vestibular neuritis. Lesions of the root entry zone that can be lacunar, but they may signify actually significant basilar artery disease, which is interesting. This lesion can present this with a unidirectional nystagmus, but it did have a important vertical component, which is illustrated here. And then this is a lesion near the vestibular nucleus, also from Dr. Tai Hong. Dorsal medullary infarct can cause central vestibulopathy with mixed central and peripheral vestibular findings. This was from Dr. Lee from Korea, published in Stroke. And so what we had here was 172 patients, 18 had signs of dorsal medullary syndromes. Primarily isolated vertigo because involving primarily the medial vestibular nucleus and the prepositus hypoglossi nucleus and the inferior cerebellar peduncle. 12 of these patients had direction changing nystagmus. 8 had negative head impulse test, but importantly, 10 had a positive head impulse test. Nevertheless, they would have been picked up. 7 had skew deviation, and 6 had central head shaking nystagmus. They found a false negative rate of 7 cases. Importantly also, if you have questions as to where the lesion might be central, immediate follow-up examinations, serial examinations in the ensuing 24 hours are going to solve the problem, because most of these patients develop brainstem cerebellar signs. Why is it so early that they have a pure cerebellar vestibular symptoms? It may be that neurons in the dorsal medulla are more sensitive to ischemia than other locations in the medulla. So this is the breakdown of those cases. And then just to remind ourselves, this is the medial vestibular nucleus, very close to the foreventricle, and medial to it will be the prepositus hypoglossi nuclei. They are the neural integrators of lateral gaze, and the prepositus hypoglossi also, along with the nodulus, are the velocity storage organs. All right, this is a paper from our own cases showing locations of strokes that have very prominent vestibular isolated signs, nothing else but isolated vestibular signs. This lesion here actually caused a pure upbeat nystagmus. This patient actually had vestibular and cochlear symptoms, and the lesion was here, probably in association with a cochlear infarct. And then this was a vestibular syndrome with involving also part of the interstitial nucleus of Kattah. This patient had pure upbeat nystagmus. Subsequent to this, we had Beck that had a paper showing an infarct here that involved part of the flocculus and the inferior medial cerebellar peduncle. The patient here also had a positive head impulse, but had direction changing nystagmus as well. There are several patients with cerebellar strokes involving the flocculus. One of them from Dr. Giacovino, and ABC is one of the co-authors, show bilateral gaze-to-evoked nystagmus and, of course, signs of cerebellar flocculus abnormalities and ocular tilt reaction that was contraversive, and the head impulses directed contralateral to the lesion here, right there, was abnormal. So you always have to keep this in mind. But clearly the lesion was not a vestibular neuritis. This patient has so many other findings that you will never make a confusion with this. This will be possible lesion locations that will give you a pure vestibular presentation. It includes the inferior cerebellar peduncle, the medial cerebellar peduncle, and sometimes in the superior cerebellar peduncle, but those are more truncal ataxia presentations, along with dysarthria. All right. And then, of course, lesions in the tonsil and the nodulus. Here, the nodulus. All right, this chart is really nice. One can have this in always posted nearby. Lesions in the labyrinth causes a spontaneous nystagmus that is contralesional, positive head impulse test, and ipsiversive skew. The same with vestibular nuclear lesions. However, the head impulse test may be bilaterally abnormal. Nucleus prepositus hypoglossi, the positive head impulse is contralesional. Inferior cerebellar peduncle, the head impulse test will be normal, and they have a contraversive ocular tilt reaction. In floccular lesions, the positive head impulse is contralesionally positive. The ocular tilt reaction will be contraversive. Lesions of the tonsil have a normal head impulse test, and so do the lesions in the nodulus. So in conclusion, the Hinds trial is useful in acute vestibular syndrome patients with nystagmus. If the head impulse test is normal, the likely diagnosis is a pica stroke. If there is no nystagmus, vestibular neuritis will not be a part of the differential diagnosis. A normal head impulse test in an acute vestibular syndrome without nystagmus simply means that the VOR is normal. BPPV or a spontaneous episodic vertigo will be the peripheral options in the differential diagnosis. along with central lesions that can cause an acute imbalance, limb ataxia, or brain stem size. The head impulse alone can be positive in lesions that affect the VOR. In the labyrinth, scarpa ganglion, which causes the first vestibular neurons, the root entry and fascicle are synapses with the medial vestibular nucleus, which house the second vestibular neuron. In medial vestibular nuclear lesions, the head is usually bilaterally abnormal, though graded ipsilaterally. Ocular motor neurons are the afferent arc. You need normal ocular tractions and versions to test the VOR. And Daniel this morning made a point of this. In addition, the prepositors hypoglossal nuclei is involved in velocity storage. Lesions of the prepositor hypoglossal cause a contralesional positive head impulse test. Finally, cerebellar floccular stroke affects the rapid response horizontal VOR and has a positive head impulse test in 3 patients reported in 3 different articles. Those patients have many other signs of central localization. I have one more slide that I put here just to tell you what is the process that we follow here to study the patients. So to properly classify an acute vestibular syndrome, ensure that there is no spontaneous nystagmus. Need to use any method to block fixation. If horizontal nystagmus is present, do the head pitch test to exclude pseudo nystagmus. Perform the horizontal head impulse test, check for skew, do a meticulous neurologic exam, and then here, these patients have been sitting up through all of this, which is like about 15, 20 minutes. Then here I do test the vestibulospinal reflex. I must say the patient is always sitting up when I begin. If they cannot sit up, I have somebody help me hold them in the sitting position. And then here is when I test the vestibulospinal reflex. So the patient has been adapting a little bit to gravity from the supine position because they are sitting up. And then my last test is the positional testing. Thank you very much for your attention. And it is likely that soon we'll have, for next meetings, perhaps there will be data from the AVERT trial. Thank you.
Thank you, Dr. Kattah. It's a wonderful lecture, as always. And that's what we got in the comment and compliment. Wonderful lecture. Thanks a lot. I don't see any other questions here. Any questions, Sergio?
No,
Anybody else?
I would like to ask Jorge permission to show something, but I have to share my screen. Is it possible? Could you stop to share?
Permission. Of course. I see. I give you permission. I have to do it.
No, you have to stop sharing the screen.
Yes, his screen is stopped. You can stop, Dr. Carmona. You can start sharing your screen.
Sergio, you're good to share your screen.
No, Jorge.
Okay, so how do I do this?
Stop sharing.
Okay, I did. Just a minute.
Yes, Dr. Sergio, you will have to start sharing your screen. You will have to click on share screen.
Yes.
I stop.
Yes, we can see Dr. Sergio's screen.
He's good.
Can you see this? You know that man. You remember this patient?
Yes.
Interesting, because I will show that we are using the Babinski as inertial sign, but we had difficulty when the patient has problem in the abdominal muscles. So are you using this sign in acute vestibular syndrome?
I have not, Sergio. I basically did the sitting as a ataxia grade 3 if they cannot sit up like that patient. And then I stand them up with wide base, then with narrow base, and then I do tandem gait. I haven't done, we might begin doing that.
Yes, yes, because it's easy and you know, very striking.
Yes.
Okay.
Very good. So, 1 second, let me make sure there are no more additional questions. Thank you, Dr. Kattah. It was a
Thank you.
pleasure
Thank you
having
for-
you.
Thank you.
Yeah, especially when you're on call. And I don't know if we announced this. Things were a bit different in the United States when we started this conference, and things are a bit different now. We have our new president. That is
Yes.
Joe Biden. He won. They declared it.
Wow. What the news?
I know, that's good news, at least for me and Jorge, right, Jorge? With that, I want to introduce, I already introduced, so the next lecture is again with Sergio. So Sergio, I think you already have the computer screen, so we are ready to go.
Okay. This is a lecture about how the vestibular spinal sign help differentiate stroke from peripheral origin in acute vestibular syndrome. Just to remember the Higgs battery, head impulse, nystagmus, and test of Skew, and this acronym of INFARCT, which in my opinion is very useful and is still useful in Spanish also. Impulse normal, fast phase alternating or refixation on cover test, any one of these points to stroke in acute vestibular syndrome. And I want to honor the creators of these signs. Here you have Jorge Ami in his clinic. He's Michael Halmaggi visiting my clinic in Buenos Aires. We are drinking tequila here with Ian Courtois. And we are in India some years ago with David Newman-Tucker, Jacinto Asprella, and here you have Sudhir. Okay, let me show you this video making by the Michael Halmaggi group. The patient is wearing an accelerometer and we're performing the head impulse test. Probably only few of you can see any abnormality when the head velocity is less than 100 degrees. What happens when you increase the velocity? 200, and it's pretty clear that the patient had an abnormal head impulse to the left. And now we increase the velocity till 300, and now it's very clear. But you see that it's more difficult to perform the movement. So remember that less degrees, more accuracy, more speed, less error, but you are more expert, has less sensitivity, but more specificity. Those facts are proven in different papers. So another way to separate central from peripheral is the vestibular, the nystagmus. The vestibular type nystagmus obey to Alexander law and increase in the sense of the fast phase. Acute unilateral cerebellar brainstem stroke might look like neuritis, but sometimes declare themselves with the duration changes nystagmus. And this is the key. And this is, in my opinion, easier to see for no expert than head impulse. Well, Jorge was talking about this. It's just to show you the VOR arc, starting in the peripheral receptor and ending in the ocular motor nuclei. You had the vestibular neuritis, you had the pathway interrupt, and you had a positive head impulse. If the lesion is in the dorsal vermis or flocculus, you have a negative head impulse, but nothing is perfect. And when you have a combination of both, you can have peripheral and central signs in combination. Recently, I was asked in a congress in Italy to talk about the acute vestibular syndrome, the situation in Latin America. I say that the hints was, of course, highly sensitive and specific, but in our countries, we had lots of facilities, especially MRI in the public hospitals, lack of training of general physician and even neurologists and ANT residents to diagnose the acute vestibular syndrome, misinterpretation about vertigo causes, always benign, stone detached in the air, and lack of protocols like the protocol that we had for cardiac infarcts. Well, in Italy, they perform a quest and ask to the general physician, which case would you prefer to evaluate? The first one is abdominal pain in a young adult pregnant, 8-month, allergic to paracetamol. The second is a vertigo and postural instability in adult smokers, previous cardiac infarct. And the third one is a head trauma with occipital bleeding, acute alcoholism, homeless subject, poor sanitation, and aggression towards staff. The vast majority of the general physicians choose not to see vertigo patients. So they had basically the same problem in Italy, misdiagnosis of dangerous disease, long permanence in emergency room of 9 cases, inappropriate expert consultation, and indiscriminate use of head imaging, especially head CT scan, in up to 80% of vertigo patients. For this reason, they think of the possibilities, and one was to provide emergency department with a spare neurologist, which is impossible, or to train the emergency physician in the management of vertiginous patient. They produce this paper, standing algorithm, and they have a successful follow-up, but the system of the health in Italy permits that the emergency room physicians were well trained. Well, after 10 years of use, hints, presence, and issues is not easily learned unless explained by an expert, especially for emergency room physicians. Current stroke protocols do not include, are not very efficient at detecting stroke in the posterior territory, and its sensitivity and specificity are excellent in case of vestibular neuritis and empiric infarct, but based on our experience, it's only 50% in case of ICA infarcts. Let me show you this case. It's a patient with acute vestibular syndrome. You can see he has a strong right beating spontaneous nystagmus, a bit skew, but the important feature here is that the nystagmus doesn't change the direction. What happened with the head impulse? As you can see, the head impulse to the left is very positive. Strongly positive. So we start a protocol with these goals to assess the usefulness of vestibulospinal signs in acute vestibular differential diagnosis and compare it to HINS, to propose a simpler test to detect acute vestibular syndrome caused by central lesions. And in 2016, we published this paper in Frontiers. Now it's an international multi-center protocol in Universidad de Salamanca, Dr. Batuecas, in Israel, Dr. Carlos Gordon, who is taking part of this meeting, and in 2 centers in Argentina. Recently, we had Dr. Lemos from Portugal, and we are adding more and more patients. Now we have 50 new patients using this protocol. Well, we follow the acute vestibular syndrome definition of the Varani Society, and in this paper, we include 114 retrospective patients and 37 new patients at this moment. We evaluate the hearing and the truncal ataxia in 3 grades. Grade 1, mild to moderate imbalance when walking independently. Grade 2, severe imbalance when standing, but can not walk without support. And grade 3, falling from upright posture. So grade 3 patient cannot walk. So let me show you what happened with this ICA patient. When we asked him to get out of the bed, he practically cannot walk. So all the doubts finish. The patient fall down. So we had the Babinski as inertia sign, and it was considered positive when the patient could not sit up, and negative when the patient managed to sit up with arms crossed over the chest. The Perronti sign had some false positive when the patient had some problem in the abdominal musculature. Here is the original publication of the Babinski at the beginning of the last century. And here we had a pica patient.
Trata de sentarte. Dale, sentate, dale, vamos. Trata de sentarte, vamos.
Cannot sit. And if you provide support, you can. Well, this is the case of Jorge's I showed before. What about the risk factor and the different in age? Well, look at the age is almost the same in our series of stroke of vestibular neuritis, but the risk factors are very relevant. 3 times hypertension, 5 times diabetes, 4 times smoking, 3 times dyslipidemia, and obesity. Only alcoholism was almost the same. And here we have the sensitivity and the specificity of HINS in comparison with high degrees ataxia, high grades ataxia 2 or 3. You can see that the ataxia 2-3 have 93% of sensitivity against HINS, that obviously is 100%. Well, none of the patients with acute vestibular syndrome was free from some grade of truncal ataxia. And here we can see by central syndromes, the sensitivity and specificity of grade 3 ataxia in ICA and PICA lesions. The grade of ataxia was not found to be affected by the patient age. And I will show you the result of the Babinski as inertia sign. Here you have the etiology of our sample. 61% was neuritis, 30% was pica stroke, and almost 10% ICA stroke. David C. gave me these beautiful slides that shows the segregation of semicircular canal and otolith projection in the lower brainstem. You can see that the semicircular canals project to the rostral vestibular complex and the otolith to the lower vestibular complex. But semicircular canal and otolith project to the flocculus, and you can see here that the ICA irrigates the rostral complex, the pica, the caudal complex, but in a cerebellum, ICA irrigates the otolith flocculus, and it can explain because why this patient with ICA syndromes has always high-grade ataxia. Moreover, the ICA infarcts can have different mechanisms, arterial or embolic stroke, and it can explain why the patient had so many presentations. Let me show you this beautiful cartoon of published in Journal of Neurological Science that shows that ICA infarcts can infarct the complete labyrinth, only the cochlea, so you have to be careful with the sudden deafness, only the vestibular, the superior vestibular artery, so the patient has a syndrome that is impossible to be differentiated of a vestibular neuritis, just the inferior part of the labyrinth, or can happen that the labyrinth is not, doesn't have any compromise, and you have directly an infarct. All the situation we have in this group. So you have to be very carefully, especially with ICA infarcts. So a protocol based on vestibular spinal science might be very useful because it has basis in neurophysiology and anatomy, does not require any previous training, and it might be performed by any physician and even by nurses. It is more comfortable for the patient, and it prevents the bias caused by many observers. Though its specificity is low, its sensitivity is very high, and that is what counts in emergencies, having not false negatives. So we propose the flow chart. If the patient don't have ataxia, always is peripheral. If the patient had grade 1 ataxia, there's a low probability of central lesion, only 7%. If the patient had grade 2 ataxia, you can separate in both groups, in two groups, with flexion and synergy. And in this case, it's a central lesion, or without positive flexion and synergy. And in this case, it does not rule out a central lesion, but the sensitivity is still good, 72%. And if the patient had grade 3 ataxia, always is a central lesion. Leading by Asif, we published recently this paper this year, very useful to telemedicine, using all the things that we learned about hints and about the use of vestibular spinal signs. And using the Nystagmus, we can use this protocol. Is you have the patient with grade 2 ataxia and peripheral characteristics of Nystagmus the causes are always peripheral. The nystagmus has central characteristics, is a central lesion. If the ataxia is grade 2 or 3, high-grade ataxias. For grade 2, with central nystagmus, central lesion, with peripheral, you need a neurotologist, as Jorge had shown, because this is probably the most tricky situation. But if you have grade 3 ataxia, it's always a central lesion. Well, muchas gracias. Thank you for your attention.
Thank you, Sergio. I don't see any particular questions here. Jorge?
Yes, that was great, Sergio. In our first paper, the inclusion criteria was acute vestibular syndrome and also ataxia. And we have about 25% of patients that would have been probably in the 2-3 category. And they were central always. So we didn't really emphasize that there, but it's in the tables and the supplementary material. So I think that the degree of ataxia clearly helps you figure it out. Every patient that we had to have that needed help to stay sitting up, that was a grade 3 ataxia and almost always associated with an acute lateral medullary stroke.
But there is an important point, Jorge, practical point. You had to ask the patient to get out the bed. Because if you ask the patient, can you walk? Say, no, I feel very dizzy, I cannot walk at all. But you had to remove the patient or to see the patient, like I have shown in your video, and you had to try it. Otherwise, it's confusing.
I totally agree with that. Totally. This is the way we did it, and we held the patient for a while and see if they will actually recover their balance. And sometimes the whole exam had to be performed with somebody holding the patient sitting. Yeah. Great.
Okay. Yeah. Well, we will move to the last lecture in this day, which is